Okay, I guess I'm live. Hi, this is Elliot Fishman, and welcome to our latest talk. And this is going to be on CT of the uncommon kidney masses. I was putting together a talk for CTisus that'll be out in a little bit because I do prepare them, we create them, and then we present one new one every week. So this one probably will take a little bit of time to show up, but I thought I would share some information with you. Um, One of the things about renal mass is we talk about clear cell renal cell carcinoma that makes up about 80 or 85% of renal masses, renal cancers, and then about 15% are going to end up being lesions like papillary renal cell carcinoma. We speak about how you tell the difference between papillary and clear cell. The clear cell are very vascular, typically 120 and over in terms of attenuation. Papillary or hypovascular, well defined, typically under 90 Hounsfield units. So that works out pretty well as a way of being able to separate the two. And again, papillary, particularly when they're small, are one of those lesions that we typically will have the capability to follow, right? Because it's one of those that tends to be relatively benign. So it's just not quite the same problem we typically will have with the clear cell. There's another one that's about 5%, and that's chromophobe. Those are uncommon. They're usually well defined, very well sharply marginated. They can be small, they can be large. The thing about them is that they aren't very vascular. They have good 5-year survival, the best 5-year survival. They can easily be resected. Usually you can do a partial nephrectomy. You don't have to do a partial nephrectomy, but you can, and that works out very well. The patient appearance on the CT, again, is sharply marginated, relatively hypovascular. So in some ways, it kind of looks like a papillary, kind of a central scar. We talk about transitional cell carcinomas. We're doing an RSNA exhibit on that, where TCCs can be seen on the early phase, soft tissue density, renal pelvis, or in the calyces. And then, of course, we can talk about the fact that it's probably best seen on excretory phase, particularly when there's small lesions in the calyces. So we talk about those. Transitional cells can be multifocal, so you want to look at the kidney, look at the ureter, look at the bladder. 40% of patients with a kidney TCC will develop an extra site of disease, be it ureter or be it bladder. Remember, when you treat TCCs, even when they're small, it's a nephrectomy, remove the ureter and remove part of the bladder. That tends to do very well. We talk about cystic renal lesions that are atypical. There's something called the MEST, M-E-S-T, not a mess, but M-E-S-T, mixed epithelial stromal tumors. They're more common in younger patients. They're usually large masses. They're cystic with septations and nodularity. They are considered low-grade malignant. Patients will get them resected. The patients will do very well when those lesions are resected. So that's a really good way of thinking about those lesions. It's a very easy way to think about them. We talk also how they look. They often can look like multilocular cystic nephromas. That's often what they're confused with. They're typically considered Bosniak 3 or Bosniak 4 lesions, but typically that's not going to be the problem that you do face. Again, it's how you basically will end up taking care of those lesions that becomes very important to you. We also talk about metastasis as being an uncommon tumor. Now, you can have Mets from a contralateral renal cell carcinoma. That does happen with, particularly with clear cell. You can have Mets to the kidney from melanoma. You can have Mets to the kidney from lung cancer, breast cancer are all possibilities. It's not the typical thing you think about, so it's really a difficult diagnosis to make because it typically looks like a renal cell. When they're not very vascular, it looks like a papillary. When they're vascular, it looks like a renal cell. So if you have one, you can think about the other one, but that's not very common. We also talk about lymphoma as being an uncommon renal mass. Lymphoma can be a solid mass, can be multiple masses, can be one kidney or both kidneys, can involve the perirenal space or pararenal space. You may only see lymphoma involving the kidney, or it can involve the kidney and liver or spleen, so multiple solid organs. The amount of adenopathy you see with lymphoma can be very variable. You may see minimal adenopathy or no adenopathy, or extensive adenopathy. When you think about lymphoma of the kidney, it's usually a hypovascular lesion, so you don't see any neovascularity. You can see displacement of vessels. I have seen one case of renal vein involvement, but that's pretty rare. So typically you're talking about multiple hypovascular lesions. Again, when you see lymphoma and it's only the kidney, or it's even the kidney and the spleen, you think about lymphoma. You also think about metastasis like melanoma. You can think about a few types of processes like that. You can see sarcoidosis, which involves the spleen, involves the kidney, and involves the liver. But usually the kidney lesions you don't see, they're just too small, so it's typically not a problem. So lymphoma is nice, solid, single or multiple masses, hypovascular. So you can see in that hypovascular category, we typically talk about a papillary renal cell, but you can see metastasis, you can see chromophobe lesions, and of course you could see lymphoma. So it's kind of a real spectrum of involvement. We do have a lot of cases on CTisus in the teaching files. It's a good place to look. Again, protocols for kidneys, just so we all know. I do like to do non-contrast because sometimes you can see some information, surely in terms of calcifications if you're evaluating hematuria. If you know the patient has a mass definitely present, I'm not sure the non-contrast helps that much because you're going to get arterial, venous, and delayed phase imaging. Again, lymphoma may be seen best on venous phase, but you will see it well typically on all phases, but because it's hypovascular, venous works out very nicely. So you really want to take a look very carefully at those cases. Coronals work very well in looking at the kidney in general. And again, look closely at the renal artery, it can be encased. Look at the renal vein. Again, almost any tumor, particularly clear cell renal cell carcinoma and lymphoma, can grow directly into the renal vein, and that can be important. You look for the extent, it could be renal vein into the IVC. So that's basically some unusual renal masses. I'm actually working right now on reading films, and then I'm preparing tonight. We will have Juan Ferez, who's head of AI for Microsoft, speaking to us on ChatGPT and how it's going to change everything in medicine. Probably good to be learning about ChatGPT because it has great opportunities to help us do our work and help us move a little bit faster. Anyway, with that, I hope you have a great day. And let me just see. Felix from Ghana is here. Hassan has a question, not about this, about accessory spleens. I think both can work well. I think CT is actually better. When you have an accessory spleen, it matches the enhancement of the normal spleen. If it's a neuroendocrine tumor, which is the differential diagnosis, they do not match. Typically in arterial phase imaging, the neuroendocrine tumor is brighter and enhances differently than the spleen does. So that works out very well. Sometimes neither work well, then you could do a nuclear medicine study, a liver spleen scan to see if there's uptake. But anyway, that's a different topic and a different time. But anyway, I hope everybody has a great day and see you later.